Well, welcome to Professor Omar Faiz for this second episode on the surgery for ulcerative colitis. We talked in the first episode about emergency subtotal colectomy in great detail, but now we're going to talk about surgery appropriate to the elective setting, where the patient has either had the subtotal colectomy or has slowly come to the need for a colectomy because of failed medical management or other problems such as dysplasia or even a small cancer. First of all, Omar, welcome again.
Thank you.
And in Britain, everybody knows about pouch surgery and pan-proctocolectomy and ileorectal anastomosis. What proportion of patients in Britain today are having which operations?
You mean of the people who've had a subtotal colectomy?
Yeah.
So yes, if we think sort of 20% of patients with ulcerative colitis historically will have had a subtotal colectomy. Surprisingly, Peter, only 1/3 of those have a restorative procedure. So, and by restorative procedure, I mean effectively an ileoanal pouch. There's a very small number who will have an ileorectal anastomosis. But the vast majority will either stay as they are with a subtotal colectomy and end ileostomy with keeping the rectal stump in situ and having sort of 2 yearly surveillance. Some of those will choose to go on to having a proctocolectomy, but it's only a minority. I think that surprised me enormously. We conducted this study and published it a year or two ago, and it surprised me enormously that actually it was such a low number in our country.
And they're staying with the subtotal colectomy and retained rectum because they're too old to have another operation, or because they can't get round to it, or
Well, we don't know what the reason is. We don't know exactly what the reason is. And I mean, I'm not sure. I think there may be some good reasons in many instances where patients are appropriately assessed for restorative options, they're counselled appropriately, and they choose very clearly to opt away from that. I think there are other instances where a lot of the surgery and how we've configured services in the UK means that sort of patients don't necessarily always end up having their colectomy in a centre where they may be proficient in restorative techniques such as ileoanal pouch surgery, and it may well be that those patients don't find their way,
or don't want to travel,
or for whatever reason don't actually sort of take the next step.
But there are some patients whose symptoms from the retained rectum are so severe in terms of mucus discharge and irritation that they'll go on to surgery.
I think there are certainly those who are led by symptoms. I think there is another group in whom gradual stenosis occurs, prohibiting any form of surveillance. And there's another group who actually sort of, either develop cancer or are extremely anxious of the prospects of developing cancer, who will opt to just have something definitive like a proctocolectomy.
And you mentioned IRA, ileorectal anastomosis, being relatively unused in the UK. We know in Sweden it's much more common and pouches are less frequent. Why do you think that is?
It's interesting. We seem to have evolved our surgical techniques or our surgical strategy for ulcerative colitis in quite different ways in two countries that seem geographically reasonably close together. Our strategy is much more in keeping with that of the United States, I think, in the rest of the world, to be honest, whereas in Sweden they do seem to have a slightly different algorithm. Over the last 4 years, we've been running a collaborative research project with Swedish surgeons to try and explore this question. Because I think it's fair to say, Peter, and you will remember the days when IRA was used for ulcerative colitis, and many UK surgeons report pretty dreadful outcome to those days with patients with extreme frequency, tenesmus, real difficulty sort of leaving the house. And yet we've got this other country where they've adopted this technique and they seem to be employing it sort of successfully in a way that we weren't able to. Now, through this research collaboration that we've maintained with the Swedish surgeons, we've explored English and Swedish data sets to just try and work out what does go on. And interestingly, like I said to you, that only 1/3 of our patients in this country will have a restorative option, of which over 90% of those are pouches, and a very small single figures number percentage are ileorectals. If you look at Sweden, 50% of their patients, as opposed to the third that I mentioned, will actually undergo a restorative procedure. But actually the majority of their restorative procedures will be ileorectal anastomosis procedures, and a minority pouches. Some of those ileorectals will then convert to pouches at a later date.
Or even to end ileostomy.
Or to end ileostomy, yeah.
Okay, well, let's go on to the pouch, because that's a big deal for someone who wants to do colorectal surgery and be seen as a specialist in it. And it's almost a seminal operation for them to learn and understand. Tell us your technique. We were saying that earlier that you try and do this laparoscopically or laparoscopic assisted. What's your technique?
It's changed enormously over the sort of last sort of 15 years really. Certainly when I was coming through as a registrar and a senior registrar, and here at St Mark's, it was predominantly being done as an open operation, and just towards the very tail end of my training were people starting to think about using laparoscopy for the technique. Now that's become pretty much the standard in many high volume centres, pouch centres, that will do laparoscopic surgery. And I think that evolution started probably about 10 years ago. It certainly started as a sort of multi-port technique. Certain colleagues then modified it to a single incision technique. And then I think more recently, you look at the last 3 to 4 years, and we've been using, again, minimal access surgery, but from a transanal approach. So we've been doing the retrograde dissections from below in order to meet the pelvic dissection from above.
Sort of tap-me procedure.
Yeah, it's effectively the TA pouch, the sort of tap-me equivalent,
Yeah, and has that really helped? Do you think there's an advantage there? There's quite a lot of debate about tap-me on the rectal.
There is. We're currently about to start a research project called Circles, investigating whether or not it does actually help. Intuitively, I think it will help. The reason that I think it will is predominantly relates to the anastomosis as opposed to the dissection. Certainly in my colitic pouches, I'll adopt a close rectal dissection anyway, so I try to preserve the mesorectum. So it means that doing an actual tap-me approach or a TA pouch approach from below is actually pretty straightforward. But the bit that is really important, I think, is the rectotomy, that you can select exactly the level that you want to actually create your anastomosis at. Through the double purse string technique, you also avoid what I thought was the Achilles heel of pouch surgery, which is the staple line over staple line at the anastomosis, and that's, I think, most often in the cases that I've seen where they've leaked, the site where the leakage has actually at least initiated. So the double purse string technique actually takes that out of the equation. You don't have any crossing of staple lines, and I think that might turn out to be the most significant advantage.
Yeah, I'm just interested in the mesorectum because some people might think if you're leaving the mesorectum, it's all going to be a bit crowded down there, but there's plenty of spaces there for a decent sized pouch and the mesorectum to live together.
It does look snug, and it looks and feels snug down there, and I wonder about that too. Against that, I've had other experiences the other way, where you've got a great big gaping hollow pelvis where all the small bowel wants to just go and fall directly into the minute you've actually anastomosed.
And the mesorectum protects it.
That's right. That's right. And also if you have a leak, Peter, because if you have a leak, we've now got pretty sophisticated ways of trying to deal with that and salvage quite a high rate through use of endosponge techniques into the abscess cavity, cleaning it up over the course of 2 to 3 weeks, and then a reattempt at closure. Now, that I think is probably easier to do if you've got a contained leak into the mesorectum as opposed to something.
And the mesorectum may help that to stay contained.
Absolutely.
So there's an advantage there. And your aim is to do now a single stapled anastomosis with the help of the perineal approach or the perianal approach, the TA approach, rather than a double staple technique, and just at the dentate line, almost joining up the papillae.
Yeah, so a little bit higher, and I think that's probably because in terms of symptoms and tenesmus, we don't get away with a staple line at exactly the same level as you do with a hand sewn anastomosis. So we'll aim to leave 1 centimetre or 1.5 centimetres above the dentate line.
And the technique for the pouch, because that's always of interest. I mean,
yeah.
John Nichols, who with Alan Parks brought this operation into being, did his W pouch, and before that was the S pouch, and then the J pouch of Utsunomiya has become almost world standard, hasn't it? And now, presumably that's what you're doing.
That's what we're doing. Yes, I saw John do a W pouch a couple of times, which was wonderful to watch, but I'm not sure I could emulate it myself now.
And so you're using 2 or 3 firings of the long staple?
3 firings of the 75mm GIA.
And how big do you plan to get your pouch? I used to measure them at about 250 mils with a bit of saline on when I first started. Do you bother with that?
No, I don't actually usually go through that, but I will go through the measurement more formally. I aim for a 20 centimetre.
20 centimetres, that's
length,
a long pouch.
Of pouch, but anywhere between 15 and 20. There's usually, I go for the most dependent part, the bit that's going to reach the furthest, and wherever that falls within about, with me being able to make a 15 to 20 centimetre pouch.
And what about defunction?
Yeah, so that's controversial. Increasingly, there are colleagues, some in this country, some in Europe, who aim not to defunction. I've had a number of cases where I have been unable to get the small bowel loop up to the surface. Actually, that has occurred at various times, and I've always been okay with that happening.
So you haven't defunctioned in that sense?
I haven't defunctioned because usually trying to has distorted the actual pouch when I've been trying to, and it's been under significant tension because of obviously when you create the pouch, you're going back upstream to loops that don't have the same length of mesentery, and for some reason in some of the polyposis patients that seems to be more of an issue than in the ulcerative colitis patients, and I've certainly had somewhere where I just physically couldn't actually bring the defunction limb up to the surface, so I've had to settle for not defunctioning, and I haven't experienced any problems as a result. Interestingly, I think there's when you look now, there's some evidence that's come out. So I think some very recently from Denmark looking at their entire nationwide experience, and when you look at their pouch failures, actually one of the determinants was the not diverting. So it makes you wonder whether or not the ileostomy does protect you to some extent from those very small minor leaks that perhaps happen, but healing mechanisms can actually deal with adequately, and by the time of the reversal they don't show on the gastrographin, and you can reverse them without too many problems.
Just clarify what you mean. Are you saying that the ileostomy, the loop ileostomy upstream of a pouch once it's made, seems to have a better long-term outcome for the pouch when the ileostomy is closed than those that don't have a ileostomy? That's interesting.
Yes. Right. So there seems to be some slight favour towards that, and that's only very recent evidence to support that. But it will be debated. I think there's still a certain amount of controversy that surrounds this entire area.
Okay, so we've got the pouch in place, the anastomosis, we've got a loop ileostomy above it. When are you closing this loop ileostomy in the majority of patients?
Between 2 and 3 months.
2 or 3 months, if in ideal conditions. And I don't think we'll talk about that in detail, but we need to talk about what happens to the pouch after that, in terms of both its function and the problems of pouchitis and so on. I've written on my list of things to ask you are the glory days of pouches over? Do you want to answer that?
That's an interesting question. I certainly don't think they're over. I think it's been quite interesting. We know that the volume of pouches that are done nationally has decreased in recent years. And it's interesting to sort of question why that's the case. At first glance, you might think, is that because medical treatment's working much better? Well, as I said to you in our last interview, no, we don't seem to be seeing drastically different rates in subtotal colectomy. So the number of patients coming to emergency colectomy is still broadly similar, but the number of patients who are opting for a reconstruction has actually dropped off significantly. So the question is why? There's no doubt that we have to sort of ensure that we provide high quality services for pouch patients or prospective pouch patients. I think this is a really high stakes area of surgery. We're doing this for quality of life at this point.
So we've got to provide decent services afterwards.
Yeah, absolutely.
When they run into difficulties.
And try to ensure we've got, exactly like we said in the last interview, the right surgeon in the right place at the right time doing this procedure.
And we've got our ileostomy senior nurses
absolutely
and nurse consultants looking after these patients afterwards, haven't we?
We have, but I think there's also another really important factor behind the declining pouch numbers, which is the societal shift that I think obviously the need for pouch surgery, back in the 1970s was really about some of the problems and stigma associated with the ileostomy, especially in young patients. And we have seen significant shifts in society for the better, in recent years.
Tolerating ileostomy.
That's right.
Much more.
That's right.
Than they used to. I think that's true.
Lots of younger patients who are coming to me saying, no, I'm fairly definitive that I don't want to undergo a restorative procedure.
Yeah, I was going to say, are the majority of the patients who opt for an ileostomy and a proctocolectomy and a permanent ileostomy, are they the older patients? But you've just sort of answered it slightly differently.
So historically, they have been the older patients, and certainly in terms of our selection for pouch surgery, we've known that function was poorer in patients who were over the age of 55 than they were in the younger age groups. But more recently, as I say, we have seen that sort of younger patients are tending now to opt, I wouldn't say all of them are opting for permanent ileostomies, but there are greater numbers opting for that route.
Right, let's talk about pouchitis. How do you see it? You're going to have help from your physicians again, because it does need quite a lot of medical management, and there's a lot of research and new thinking going on. What proportion of your patients get significant pouchitis, and when?
Well, I think, when you look at the statistics, it's between 30 and 50% that will get an episode at least of pouchitis. So I think acute pouchitis is extremely common after pouch surgery, but the vast majority are absolutely fine. I think it's either self-limiting or something that's managed very easily with a course of antibiotics, usually by their GP or gastroenterologist. There is the other group of patients that sort of are defined as chronic pouchitis, and that's a really small percentage of the ones that develop pouchitis, but they get chronic refractory symptoms.
Do you think some of these have had a leak, which we never really discovered?
I think that's exactly the problem, actually. And I think, ourselves, we've published on this, I think the Cleveland Clinic have published on this, that when you actually look in this group, you do find septic complications that anastomotic problems or sinuses that are usually behind some of this group. And, obviously, miraculously enough, you give them both antibiotics and they both tend to get slightly better, and then they both recur the minute that you take the antibiotics away. I think MRI scanning has actually helped us enormously, that it's actually allowed us to see some of what's going on outside of the pouch as opposed to just the luminal view.
So when you see a young patient who's thinking about a pouch, what are you going to tell them? Are you going to say you're going to go to the toilet about 5 to 6 times during the day and once or twice at night? You may get an attack of pouchitis, which is usually transitory, but 1 in 5 of you are probably going to have such unsatisfactory function that eventually you might end up with an end ileostomy. Is that the sort of advice you give them?
I'm not sure I put it like that, Peter. But yes, that over a 20-year period, that is correct. That 1 in 5 will go back to an ileostomy. But for many patients, they are say in their 20s, and they're sort of thinking, well, what happens in 10, 20 years time is a different matter. It's about what I need in my life right now. So how we process all of this information, I think, is very individual. It needs to be very individualized also.
And one thing that's always worried me, and I suppose I should ask our colleague Professor Sue Clark about this, perhaps more than you, because a lot of these patients come to her where they have to have the pouch taken out, is that so often you've lost that length of ileum and you've ended up with a ileostomy which is higher up the GI tract, therefore will function more and could be a problem.
So again, when we look at the numbers of declining pouches, again, some of that I think is this greater awareness, and perhaps through social media and how that facilitates patient-to-patient contact, is that patients do, I think, now come into this understanding that outcome isn't guaranteed with pouch surgery. And there is also some risk involved, because very often you hear the patient say, I'll just try the pouch, and if it doesn't work out, I'll just go back to the bag. And then you really do have to start the conversation again and sort of say, well, look, you don't go back to exactly the same bag.
No, you've lost that extra bit.
You've lost that extra bit, and it doesn't function the same way, and you might feel more tired as a result of the fluid and electrolyte losses. So I think patients are also now more cautious, perhaps, about the gamble attached to further complex surgery.
But we've also got to tell them that there are still complications after a pan-proctocolectomy in terms of obstruction and adhesions and so on. Maybe with the laparoscopic, in the laparoscopic era, that's not as great. But certainly when I was doing a lot of it, there were significant adhesions afterwards, which might lead to episodes of small bowel obstruction after a pan-proctocolectomy.
I think that's right. And I think, our explanation doesn't actually frighten patients away as long as it's done appropriately. I think it helps them arrive at their own decisions, which they need to in this area. But I think that is something that you have to be prepared to invest time in. Patients often need to see you 2 or 3 times. They need to sort of come back. They need to see the stoma nurses. They'll do some of their own research in all of this. And at the same time, in this area, you are running certain things in parallel. You're getting a second opinion on the pathology. You're doing anorectal physiology tests if you need to, if that's a potential issue. So there's a lot that goes into that sort of meeting, and then the sort of subsequent consultations with somebody who may or may not wish to pursue pouch surgery.
And finally, Professor Omar, Professor Faiz, what about cock pouches? I mean, we talked about Sweden earlier, which is where that came from. Do we see any great benefit? Is anybody doing them now in any quantity anywhere around the world?
They're still being done in Sweden. There are variants of the cock pouch that are being done elsewhere. There are also other newer devices that are coming out. One of them is called the Tease device, which is like a metallic implant, sort of aimed at sort of again the same intention for continent ileostomy. So I think there's renewed interest.
I think like the magnetic stoma that was tried 20, 30 years ago, that'll probably fail, won't it? It really won't work if there's a
couldn't-
foreign body there.
I
You
couldn't
couldn't possibly
commit.
come. Anyway, thank you very much for an excellent session. We've learned a lot about restorative proctocolectomy and your techniques, and explored the subject in some detail. And thank you very much for giving us your second podcast, and we hope to get you back another time to discuss the surgery of Crohn's disease, perhaps.
Thank you very much, Peter. Thank you.
Thank you.